Welcome to Module 11, where we're going to talk about complex hematologic and immunologic disorders to critical care nursing. In this module, we're going to discuss disorders affecting blood clotting, immunity, and the body's ability to respond to infections and injuries. Key conditions we'll cover include disseminated intravascular coagulation, various types of anemia, thrombocytopenia, HIV management, and complications related to cancer. Okay, let's get started. The first thing that we're going to talk to you about today is DIC, or disseminated intravascular coagulation. So, what is DIC? DIC is a complex and critical disorder in which the body's clotting mechanisms go into overdrive. Unlike typical coagulation, where the blood clots are localized to the site of an injury to stop the bleeding, DIC causes widespread clotting throughout the blood vessels. These abnormal clots are small and they form in the microcirculation across various organs, leading to what we call microvascular thrombosis. This constant clot formation quickly consumes platelets and clotting factors, which are essential, as you guys know, for the body to manage normal blood coagulation just in everyday life. So, as a result of this, the patient can experience paradoxical bleeding because essentially they run out of resources needing to form clots properly. Or, in other words, when a patient goes into DIC, they use up all their clotting factors. So, where a normal little accident, little bump here, or a little pressure on something there would cause a minor bleed, your body would fix it just on the microscopic level. Now you don't have clotting factors, and so you bleed all over the place. So I'm going to give you some of the examples of conditions that can trigger DIC. So sepsis is one of the big ones, okay? It's one of the main ones that does cause DIC, especially in the critical care setting. So with sepsis, the body is responding to a severe infection, right? And that sometimes it's obviously so extreme that it activates the coagulation pathways systemically over your whole body. For example, like a patient with a severe bacterial infection, such as a bloodstream infection caused by E. coli, they might experience DIC as the inflammatory response spirals out of control. The body, in an attempt to fight the infection, inadvertently activates the coagulation system, which will lead to that widespread clotting and depletion of the clotting factors, which then causes bleeding of the skin, the gums, GI tract, basically everywhere. So another thing that can trigger DIC is trauma and or major surgery. So trauma causes obviously a lot of bleeding. So trauma cases with significant tissue injuries, such as those resulting from like a major car accident, like a lots of stabbings, gunshot wounds, kind of things, like think lots of blood, that can trigger DIC. So, for an example, a case of massive trauma with extensive tissue damage and blood loss after, say, a multi vehicle car accident, the body's coagulation system responds intensely to stop that bleeding from that trauma. Okay. So, it's sending all the clotting factors it has to that area to basically preserve life that it can, right? But when this intense response becomes unregulated, it can lead to DIC. So your body's trying to clot and prevent bleeding, but in essence, it uses up all those clotting factors, and now it can't even clot the most simplest of bleeds, okay? So similarly to that, if you have a major surgical procedure that requires your body to send clotting factors to the area that's damaged, especially those surgical procedures that have a substantial blood loss, that can lead to DIC. So another common area that I shouldn't say common like that it happens all the time, but another area that we do see DIC is in obstetric emergencies. So you may have learned about this in your OB course, but obstetric complications such as the abruptio placentae, placental abruption, where the placenta detaches prematurely from the uterus, or like an amniotic fluid embolism, that those can both lead to DIC. And I've actually, sadly, personally seen this in real life, and it's super sad. Um, so in the abruptio placentae, the sudden release of the procoagulant substances from the placenta can trigger that massive coagulation. Likewise, when the amniotic fluid enters into the maternal circulation, it can act as a strong trigger for DIC, leading to catastrophic bleeding in a pregnant woman. And if a patient goes into DIC before they've delivered, the chance of you this is an emergency. We're sending them to the OR. We're getting all the blood products as soon as we can. But sadly, a lot of times these do end into fetal and or maternal demise. So another one is malignancy. So cancer causes sometimes DIC. So certain cancers, especially acute APL, acute promyelocytic leukemia, say that 5 times fast, they have a high risk of causing DIC. In APL, the cancer cells release procoagulant substances that continuously activate that clotting pathway. This can result in blood clotting and bleeding issues, a hallmark, obviously, of DIC, and often requires targeted treatment. So just remember that various different things can cause DIC, and you need to be keeping that in the back of your mind when you're caring for patients that have had those major surgeries, OB patients, cancer patients, especially like your leukemias, your blood cancers, and then obviously septic patients. That this you need to be looking for signs of DIC and intervene hopefully sooner than later. So the so like what a little bit more about the pathophysiology of DIC. So remember, it's an uncontrolled coagulation cascade that leads to thrombin generation, which is a big fancy way of saying that it produces blood clots. Okay, so those extensive clots form in all the small blood vessels around your body. So as the clotting factors and platelets are being consumed because you're sending all these clots around to places in your body, the body paradoxically, and when you hear that word paradox, it means oppositely, it becomes prone to bleeding. Okay, so we're creating all these clots, sending it out to the body, and then now we've used up all of our clotting factors, and now we become like uber sensitive to bleeding. These small clots disrupt the blood flow to organs, so there could be little ischemic infarctions in different organs in the body, and so that can lead to multi-organ failure if you don't manage it early. So clinically, DIC presents as a mix of both bleeding and clotting complications. And now you can kind of probably think about how do you treat this? If you want to treat the clotting, it's going to cause more bleeding, but they're bleeding. So they're bleeding and clotting. So how do we even treat it? Start thinking. So clinical complications of DIC. They are severe, okay? The microvascular clots can cause the ischemia that we already talked about, which is causing the deprivation of oxygen to different organs in your body, which can lead to the failure of that organ. At the same time, the patients are exhibiting the bleeding in various areas. Most frequently, it's like in the skin, and you'll see like petechiae, purpura, and stuff. And that's because, or IV sites. IV sites is another area, like you'll see like blood oozing around the IV site. And so you have to keep that in mind. And mucous membranes, another thing, the nose, the mouth, the rectum, you're going to start seeing bleeding, okay? So when you leave these unaddressed, DIC can escalate into a life-threatening multi-organ failure. Okay, so once DIC is set into motion, it leads to that cascade, right, that we already talked about, okay? And it can really affect every single system in the whole body. So it's so important for you guys to understand the underlying mechanisms and the consequences of DIC. So we already kind of talked about it, but organ ischemia is one of the big ones, right? So it's a hallmark complication of DIC, and it occurs when those macrovascular clots go throughout the body and clot up in the vasculature of that organ, leading to infarction, okay? So those clots reduce the blood flow, cutting off the oxygen. And so, like an example, so they can be sent to the kidneys, and it could obstruct the blood flow in the kidneys, and that's going to result in acute kidney injury, as the kidneys are very sensitive, as we know, to oxygen deprivation. Similarly, the clots can form in the small vessels of the lungs, and so the patient might develop acute respiratory distress, ARDS, leading to breathing difficulties, and then again exacerbating the poor oxygenation in the body. Now, if in the brain, there's those microvascular clots, that's going to obviously lead to a reduced blood flow to the sorry, to the brain, which would result in neurological changes such as confusion, altered mental status, or your patients could even present like a stroke-like symptom. And technically, it is a stroke. If there's a clot blocking blood from getting to the brain, right? So the widespread ischemia can set the stage for, again, multi-organ dysfunction. Okay, and as you can see, like literally can affect any single organ in your whole body. So what do we do? So when a patient has DIC, it's going to be particularly challenging, okay, because it involves addressing both that excessive clotting and also well as the bleeding. So, what the treatment is going to focus on is identifying and addressing the underlying cause of the DIC while supporting the patient's coagulation systems to prevent the further complications. So, let me break it down a little bit more in the approaches to managing DIC, including some of the specific meds that we might be used to under controlled conditions. That's not always used. So, treating the underlying cause. First, we need to figure out what is causing the DIC. So, since DIC is often secondary to another severe illness like sepsis, trauma, cancer that we already talked about, we need to control that or cure or treat that primary issue first, right? Because we need to fix that so that we're stop using up all of our clotting disorders or the overactivation of the clotting cascade. Okay, so if the patient has sepsis, aggressive antibiotic therapy is administered to control the infection. If the patient is like a trauma patient, surgical intervention might be required to repair the damaged tissue, and reduce that inflammatory response that contributes to DIC. And those OB cases, like the placental abruption, um, managing the obstetric emergency is priority, like to the OR. Okay, so supportive care with blood products. Because DIC is going to deplete the body's platelets and clotting factors, what we often do is give the patient transfusions to replace these components. And that's going to include several different things. Platelets are one of the more common things, obviously. We're going to give platelets when the platelet count drops significantly, usually below 20 to 30,000, to reduce the bleeding risk. We're also going to be giving fresh frozen plasma, or FFP. Um, and I'm sorry, the screen says FF. It's FFP. It contains essential clotting factors in fresh frozen plasma, and it's used to replenish those depleted by the continuous clotting in the DIC. FFP transfusions can help restore coagulation factor levels, helping to stabilize that bleeding. So another thing that we might give is cryoprecipitate, which this is really used more for patients with their fibrinogen levels are low. What it does is it's rich in fibrinogen and factors 8 and 13, I think it is, yes, which are vital to clot formation. Okay, so medication management in DIC. So yes, so technically it's blood and med. Yes, we're giving it to them. So we're going to be giving different blood products. Okay, but although using medications in DIC requires that delicate balance, several agents can help in addition to those bleeding factors. Sorry, several meds can help along because we just talked about blood products, and those are going to mostly help with the clotting. But what are we going to do about the bleeding, right? So hopefully, hopefully we've given oh, I'm sorry. We just talked about clotting, blood products that are going to both help with both the bleeding, with the clotting factors, as well as the clotting. I hope I'm not mixing that up for you guys. They're helping on both ends. We're also going to give possibly heparin. Low dose heparin might be used in some specific cases of chronic or low grade DIC, especially when those the thrombosis and the thrombotic complications are severe and they outweigh the bleeding risk. So we're more worried about the clots and the bleeding, we might be giving heparin. Okay. So heparin is generally, though, avoided in cases of acute DIC with significant bleeding risk unless that thrombosis is life-threatening and localized. So if there's small clots, or I'm sorry, big clots to the brain or something that's going to, or the lungs, like a pulmonary embolism or something, and we really need to treat the clot more than we're worried about the bleeding, then because we can be replenishing your blood over and over again, right? We can be giving you blood products, right? And if we have them, obviously, but we could be replenishing the blood if you're bleeding out to maintain your fluid volume. But if we have a clot that's preventing oxygen from getting to like your vital organs, like that's going to cause death. So we have some. That's why heparin might be used in some of those big clots that are causing those organ damage in like the brain, the lungs. I mean, even the kidneys. We also might be giving antifibrinolytics to the patient. So we're going to be giving those where bleeding is severe and fibrinolysis. So fibrinolysis. Lysis means to split, cut down. So that's the breakdown of clots. So when the patient has fibrinolysis and is exacerbating blood loss, so they're bleeding more than they're clotting, okay? So those antifibrinolytics may be considered in those cases. So what they're going to do is they're going to prevent the breakdown of the fibrin, helping to stabilize what clots do already currently exist. Okay, so this is where bleeding is worse than the clots. See, again, it's always a delicate balance between blood loss and clots. Okay, so we also might be giving activated protein C or APC. In cases of sepsis-induced DIC, recombinant human activated protein C has been used in the past to reduce inflammation, help modulate the clotting. However, it's important to say this, that the therapy is no longer widely used due to some mixed outcomes in the clinical trial. So I just wanted to mention it. You might see it, but it's not common. Okay. So vitamin K is another thing that we might give. So if you remember vitamin K from another course, you probably remember it from your course where you talk about newborns and they get vitamin K. So in some cases, vitamin K might be administered to support the clotting factor production, particularly if the patient has liver dysfunction that contributes to clotting factor depletion. Remember that vitamin K is necessary for synthesizing clotting factors. It's 2, 7, 9, and 10. I think, yeah, 2, 7, 9, and 10, which are critical in basically the clotting cascade. We already know that. Okay, anyways, so monitor and support measures. So as a nurse, so when your patient's in DIC, you're going to be doing lots of monitoring. We're going to be doing lots of lab tests. So we're going to be going over PT, PTT, fibrinogen levels, platelet counts. You're going to be doing these frequently, okay, because we need to monitor like how they are affecting things and if things are getting worse or better, okay? So um, PT, APT, these are going to help monitor the clotting function and guide treatment. Like, is the blood clotting? APT and APT, clotting. Fibrinogen, um, so remember, fibrinogen is consumed in DIC. So if the levels have to be monitored to maintain above a critical threshold to prevent bleeding. So if fibrinogen levels drop low, that means the patient's more at risk for bleeding. We're going to be looking at platelet counts. So we're going to be regularly checking those to determine if the need for transfusion and to monitor the body's response to interventions. Okay. So lots to remember, lots of different ways, and it really depends on what's the bigger issue with your patient on what you're going to go for. So now let's switch gears and let's talk about thrombocytopenia. Again, you might have already gone over this in a previous course, so it's kind of an overarching level, but we're going to briefly go over it. Okay, so thrombocytopenia, what is it? It's a condition characterized by low platelet levels. It has various types with distinct causes, and depending on the type is how we decide how to manage it, okay? So the first one is HIT, which HIT is heparin-induced thrombocytopenia. It is an immune reaction to heparin. So what that does is it leads to a drop in the platelet count and increased clotting risk in the patients. TTP causes abnormal platelet aggregation, which means like how they stick together. And so um, yeah, so TTP. Okay, trying to get these things. So HIT is heparin induced. So heparin is causing issues with platelets. Okay, so not as many platelets are coming out, and the platelet count is going down, so increased clotting risk. TTP causes abnormal platelet aggregation, and then ITP involves the immune system attacking platelets. So it's an autoimmune disorder, and it's actually going to go after those platelets. So all three can lead to bleeding issues, obviously, right? So TTP, and ITP, they have the word purpura in it, and that means because they're probably going to lead to bleeding, and it typically has, you'll see purpura over the body, like the little red marks all over the skin. If you don't remember what purpura looks like, Google it, look at a picture. It's very important. If you see purpura on your patient, you need to be thinking that it could be something super serious. It may not be, but it could be. Meningitis is one of those things. Okay, so now let's compare the three. So the management for each type of thrombocytopenia varies. So in HIT, that's the heparin-induced one, discontinuing the heparin and using an alternative anticoagulant is what we're going to do. For TTP, the thrombotic thrombocytopenia purpura, that requires plasmapheresis to remove antibodies alongside the immunosuppressants. So we're going to be um, suppressing the immune system so that it doesn't cause those issues. And then ITP, we're going to give corticosteroids to suppress immune activity. And IV immunoglobulin, we could also give those, and because that might increase the platelet count. Sometimes, a lot of times, these are just supportive, like ITP and TTP. A lot of times, we're just going to do supportive measures and monitor. We don't necessarily treat, but these are some of the treatments we could do if it becomes severe. So anemias. Switching gears again, lots of things to cover. Okay, again, you should know a little bit about anemias, but this should be a review. So anemia is a condition where the body lacks sufficient healthy red blood cells to carry the adequate oxygen. So basically, the vehicles getting the oxygen to the places we don't they can't carry the oxygen, can't get inside the vehicle. Okay, so your body can get the oxygen in the body, but it can't attach it to the vehicle to get it to the different organs. Okay, so there's different types of anemia. So the more common one that people know about is iron deficiency anemia, and it's just what it says, that it's because there's a lack of iron to make the blood cells where they can grow to the point or develop to the point where they can carry that oxygen. Okay, so this is more common in young adults and older patients, and we manage it by giving iron supplementation and or changing the diet. So you can also see sometimes vegans that if they're not using iron-rich foods, so especially the non-meat eaters, and they're not supplementing with iron-rich vegetables and stuff, they can have iron deficiency anemia. You also can see this in pregnancy as well. So pernicious anemia, that results from a vitamin B12 deficiency. And how we treat it is we give vitamin B12 injections. And just to note, oral B12, your body cannot really absorb it, metabolize it. Very little gets into the system. The best way to get B12 is IM injections, just in case you didn't know. Aplastic anemia is the third one that we're going to talk about. So that it's actually not the third one, but third one on this page. Okay, so that impacts the bone marrow. Okay, so we might need to do supportive transfusions or bone marrow stimulants to start producing better red blood cells that can carry that oxygen. So, in the critical care setting, anemia is very common, okay, and it's a complex challenge that can be sometimes hard to overcome when you don't understand the initial underlying cause of what is causing the anemia, okay? So, in the critical setting, anemia often comes from a combination of factors unique to what the patient is actually going through and why they're in the critical care setting to begin with. So, some causes of anemia in the critical care setting specifically. So the last slide, we were kind of going over anemias that can kind of be seen in clinic and the worldview, but now we're talking about a little bit more specific to the critical care setting, more specifically to ICU. So blood loss, frequent blood sampling, surgical procedures, internal bleeding, all those things can lead to substantial blood loss over time, lowering the RBC count, okay? Chronic illness and inflammatory response. So those things like kidney disease, heart failure, or which are common with ICU patients, right? That can suppress erythropoiesis. And if you remember what erythropoiesis is that's the production of RBCs. So the inflammatory response, which is part of your immune system, seen in those like in severe infections, trauma, sepsis, and stuff, that's also going to suppress and impair the RBC production, which can lead to anemias. Okay. Nutritional deficiencies, we kind of already talked about those again, but in many of our critical ill patients, they have limited nutritional intake, which can lead to those deficiencies and those essential nutrients like iron, like B12, and folic acid, and those are all necessary for RBC production. Okay, so also in the critical care setting, a lot of our patients have issues with oxygenation and organ function, right? So So, anemia in critically ill patients reduces oxygen carrying capacity, which can compromise oxygen delivery to vital organs, especially in those who are already at risk for hypoxia due to respiratory issues like your ARDS patients. Okay. So, this reduced oxygen availability can impair the organ function across systemically, the entire body, and that can delay healing. It can contribute to fatigue, weight, weakness, and also just poor patient outcomes. So what are we going to do for these critically ill patients? We're going to talk about very similar, blood transfusions, iron supplementations, and erythropoiesis to stimulate the red blood cell production. Very similar to what's outside. It's just that sometimes it's caused a little by the ICU itself can cause anemia just by the nature of what the patient's going through, if that makes sense. So anemia in older adults. So older adults are more susceptible to anemia, often due to chronic illnesses, malnutrition, and age-related bone marrow changes. So as a nurse, you got to recognize these causes, know when your patients are more at risk, and you need to look for like personalized, patient-specific management to these care plans. So a lot of times this is going to involve nutritional support and also monitoring for complications linked to chronic conditions. So um, nutritional support is going to be the big one. So it's going to be encouraging those iron-rich foods if iron deficiency is the cause. Especially in the hospital setting, remember patients can order and select their own meals. So you might be needing to be in there and helping them pick out. So I saw that your iron is a little low and you're a little anemic, and so these are the foods on the menu, and you can point them out that might help, with increasing your iron intake because we all hate those iron pills because they're huge, FYI. And patients will often be a lot more willing to like listen to you if the fix is simple diet change, especially in the hospital. Okay, so now let's talk about a different form of anemia, sickle cell. Again, hopefully you've already touched on sickle cell at some point in your nursing education journey, but we're going to go over it a little bit better today. Okay, so sickle cell anemia, remember that's a genetic disorder where the red blood cells contain abnormal form of hemoglobin called hemoglobin S. And so under low oxygen conditions, the RBCs change their shape and they become a crescent shaped or sickle. Like it looks like a sickle, like the on a stick, like the Grim Reaper uses a sickle. So it looks like that crescent moon. There's a picture on your screen down at the bottom right of a sickled red blood cell. So now these aren't perfectly round, nice little red blood cells that just glide through your system. When they're sickled like that, they can kind of clot, they can stick together or cause clots in your vasculature system. And if they are causing clots, that's going to obstruct your blood flow, and that can lead to ischemic damages in various organs, depending on where the sickling is occurring. Is a way that we kind of word it. So wherever those clots form, you can have infarcts all over the body. So you can infarct your kidneys, your liver, your eyes, your skin, obviously. And remember, every time you don't get oxygen to a tissue, what happens? Pain, right? So it's super painful. Okay. So in sickle cell anemia, that abnormal HBS causes the RBCs to take that sickle shape. Okay. So unlike normal RBCs, remember, that are flexible and round and pretty and they flow easily through the blood vessels, those sickled cells are stiff and they tend to clump together. Okay. So the obstruction leads to the tissue ischemia, severe pain, and we call that vaso-occlusive crisis or sickle cell crisis. Vaso being vessels, occlusive being blockage, crisis. So vaso-occlusive crisis or sickle cell crisis. So over time, the repeated sickling and unsickling of those RBCs damage blood vessels and tissues, leading to chronic complications like organ damage, anemia, and anemia from the shortened lifespan of those RBCs. So in the ICU, what are you going to see most likely is a patient that's in crisis, okay? You may get a patient there for other concerns and they have sickle cell. And I think it's very important for me to distinguish right now. A lot of times when you're asking a patient history, they will say they have the sickle cell trait. Sickle cell trait does not mean that they have sickle cell anemia. It means that they have like a carrier of it. And for some reason, patients are always like, I have the sickle cell trait. And I'm like, well, have you ever been told you have sickle cell anemia? No. Have you had blood tests? Yes. Do your blood cells look normal? Yes. Okay, well, then you don't have sickle cell anemia. But they'll say that, and you think that they're a sickler. We call that's just layman's, well, it's just, we just call them sicklers. And they're not a sickler. So, it's important for their offspring to know if they have a trait. I mean, they might develop it, but no. Anyways, so it's important to distinguish, are they actually do they actually have sickle cell anemia, or they just have, some of the genetic factors that was passed down, but they don't actually have the issue that causes the sickling of the red blood cells. Okay. Back to the vaso-occlusive or sickle cell crisis. Okay. This is a painful crisis. Um, often, well, they'll come into the ER just in excruciating pain, and they'll get admitted to the ICU often, and they could go IMU depending on what's going on. But in crisis, we want to take that as an emergency, okay? So there's obviously the pain is a sign that somewhere in the body, typically where they're saying the pain is not getting blood, okay? So we need to take it seriously. It's like a stroke, it's like a heart attack. We're not getting blood to an organ. We need to get in there and figure out what's going on, right? Okay. So it's going to cause that severe pain to the area in which there's ischemia, okay? There's some complications of it. I think we're going to go a little bit more over it here in a second, but you can also have that acute chest syndrome, stroke, and infarct. So let me go more onto sickle cell crisis on the next page. Okay, so what we're going to do, number one is oxygen therapy. Okay, so if we're not getting, um, if we're having little minor clots and sickling, we want to give the patient oxygen. Okay, so that's going to, not only is it going to help when the blood is reestablished to the area. So you think about giving oxygen to somebody that is having a stroke or something else like that. Like you're thinking about getting oxygen to the area that's been deprived. Well, it's a twofold reason why we give it to somebody in sickle cell crisis. Okay. Yes, it will help reoxygenate the tissue that is having an infarction right now, but it also can help reduce the sickling because when you're improving that oxygen delivery, it's, like it will keep the oxygen, the red blood cells from actually turning into sickle. So it's going to prevent further issues. Okay. So we want to make sure what oxygen they're getting into their body, that they're as oxygen rich as possible. Okay. Then the number, so a lot of people are going to say pain. Pain is not a priority in sickle cell patients. Okay. IV hydration is. Okay. So hydration is going to help reduce blood viscosity. So it's going to, in essence, thin out the blood a little bit. And so that's going to reduce the blood viscosity or the thickness of the blood, which is going to improve the blood flow, reducing the risk of further occlusions. Okay. So IV fluids are used to rehydrate and prevent further sickling. So oxygen, IV hydration, then pain control. Pain is the most common symptom, and you're going to want to go to it first. Okay. But getting those IV fluids is way more important. Okay. Um, but pain is also important too. So, um, because a patient in pain, um, sorry, I just stopped. Okay, so it is a priority, but it's not the number one priority because when you're in pain, you're going to have an increased oxygen demand on your body, right? And that can lead to sickling. So calming you down where you're not having such a stress-induced, painful experience, that's going to lower the oxygen demand of your body. So you're not going to be consuming up so much oxygen, which will hopefully help prevent further sickling. So pain management is twofold as well. Like, yes, we want to treat the pain, but it can also prevent further sickling of the cells. And then, if indicated, we're going to give blood products. Okay, so we're going to transfuse the patient. That's going to help increase with good, healthy red blood cells so that we can increase that oxygen carrying capacity of those healthy red blood cells. And that's going to reduce the proportion of sickle cells in the blood system. Okay, and it's also beneficial in cases of severe anemia in the acute chest syndrome and stroke. So it's a lot like the fluids in the sense that it's going to like lower the viscosity because you're not going to have as much sickling cells clumping together. You're going to have more round, pretty smooth cells going through the blood. But yeah, those are the four big things that we're going to do for somebody in crisis. Okay. Now I will tell you, if somebody patients know one of the education things for somebody with sickle cell anemia is to basically, for all these things that we are giving them, especially oxygen IV hydration, that's a way that they can put themselves into crisis. Okay, not that anybody wants to put themselves into crisis, but if they do things that require heavy oxygen demand, like they want to go climb a mountain or something, and they go up in higher elevations, this can trigger a crisis. If they go outside on a hot, sunny day, they don't drink anything all day long, no water, no Gatorade, they drink a cup of coffee and then they go run a couple of miles, they can throw themselves into crisis because A, they increase their oxygen demand, and B, they didn't hydrate themselves. So educating these patients on hydration, hydration, hydration 24/7, that will help them, but also teaching them how to like breathe because there's a runner's like the way that you should breathe when you're running in sports and stuff. Like you should teach them those just every day. If they climb some stairs or something, like always make sure you're very well oxygenated. They also need to know that when they get sick, so let's say they have an upper respiratory infection and cold and things, where their oxygen demand might go down a little low, that could lead to crisis. So they need to be a little bit more vigilant about seeking care, so that we can prevent the crisis from occasion, so we can like open those airways, get good oxygenation. If they have sleep apnea, we need to be giving them, we put them on CPAP and those kind of things, because we need to be preventing the sickling of these cells. I hope that makes sense. Okay, switching gears again, we're going to now talk about bleeding and blood transfusions. So, yes, we've already kind of mentioned these in some way, but let's just kind of go a little bit more onto it. So, in critical care, lab studies for clotting assessments are crucial to understanding the patient's coagulation status. These tests evaluate different parts of the coagulation pathway and help guide decisions on interventions, especially in patients at risk for clotting disorders like DIC or when monitoring anticoagulation therapy, which all patients are on, we're on DVT prophylaxis and stuff like that. So we're probably, especially in the ICU, patients are more immobile. They're at risk for clotting issues, especially if they're at post-surgical and all those kind of complications. So you're going to be doing these labs on almost all your patients. So you need to understand what they are. And hopefully you already do. So this should be a review. But in case you never grasp the concept of what these labs are, let's just go for a little journey now. Okay, so let's first talk about PT and INR. PT measures the time it takes blood to clot through the extrinsic pathway, which includes factor 7. Don't remember the factor. You don't have to remember the factor. I'm just saying it, okay? Just remember PT extrinsic, X, like exit outside the body, okay? It's often used to monitor patients on warfarin therapy because warfarin affects these factors, prolonging clotting time. INR standardizes the PT results, okay, regardless of the laboratory variability, okay, because different labs have different ranges and they test differently, and so there is no universal like PT range, but the INR is what basically standardizes it so that we can make judgments and make decisions on treatment off of it. Okay, so for patients on warfarin, the INR is often kept between like 2 and 3 to maintain coagulation while minimal bleeding risk. So there is a mnemonic. Think PT for prothrombin and warfarin, both having the letters P. Remember, INR is the international standard that adjusts PT across labs. Okay, so I hope that helps. Hope it didn't confuse you. So APTT. So sometimes people call it PT and PTT, and they don't say APTT. But when you're talking about PTT, it's APTT. If that makes sense. Two T's, not one T, two T's. Okay. So PTT or APTT measures the intrinsic pathway. So PT is extrinsic, PTT is intrinsic. So it's measuring that pathway, and that's used to monitor heparin therapy as heparin prolongs clotting through that pathway. So APTT is checked frequently in patients on IV heparin infusions to ensure safe and effective dosing. Just remember that, okay? Let's see. So a way that I kind of remember this is associate the two T's in APTT with thromboplastin. I know that's not going to help you. So thromboplastin is like a bigger word, okay, than thrombobin. So like you have the one T and the two T's. So the two T's is the bigger T word. Okay, that's kind of how I remember it. You can do whatever how it is you remember it. Okay, so thromboplastin and heparin are both terms that you should link those together. Okay, so also remember that APTT requires extra time due to heparin, so it doesn't result right away. Okay, now fibrinogen level and fibrinogen degradation products, or FDP. Fibrinogen is a protein essential for clot formation. Okay, so if you have a low level of fibrinogen, that can suggest increased consumption of clotting factors. Okay, so go with me here. Fibrinogen is a protein that you need to form a clot. So if you don't have a lot of it in your system, that means that it was used up already. Okay. So if it's low, that means that we used it up to form clots. Okay. So if fibrinogen is low, that means that we used it to form clots. Okay. Just making sure we understand that. Okay. Okay, so fibrin degradation projects, you also hear the term fibrin split products. So next in your notes, right next to FDP, write fibrin split products. Know that those are interchangeable. Sometimes people use them in both ways, okay? So fibrin split products, what they are, those reflect clot breakdown, and those are elevated in conditions where clot lysis is ongoing. So lysis, remember, is to like split, cut down, break down. So if we're breaking clot lysis means we're breaking down clots. So so fibrin degradation products, review. Those are in your system when your system, like in your body, you'll pick up on those, and they're elevated when, and they show signs that they have, that your body produced these things so that they could go break down clots. So if you have those in your system, that means that your body has been breaking down clots for a while. What an example of this is D-dimer, okay? So D-dimer is measuring fibrin degradation products. So if you have an elevated FDP, D-dimer, fibrin split products, aka all the same thing, that means that your body has been already breaking, you already produced a clot and now you're breaking down clots, okay? So we do use that. Think about the things that we want to test for: a pulmonary embolism, a DVT. As soon as your body produces a clot anywhere in the system, the body has mechanisms in place that basically send warning signals, say, hey, I have a clot, you need to come and break it down. And your body will immediately start trying to break it down by producing these fibrin degradation products to go break it down, okay? So if we test and they're elevated in the system, that means that something's happening. Now, you would expect that to be elevated if after somebody just had major surgery, because your body is trying to produce clots to like repair tissue and things that it was just sliced open for, right? So like that's a normal thing. But if there's no reason why your body should be forming clots and that is elevated, that means that there's a clot somewhere in that body and we better figure out where it is. And it's probably wherever the symptoms, other symptoms the patient is expressing is coming from. If they're having difficulty breathing, probably in the lungs. If they're having severe, like abdominal pain, the clot's probably in the organ near the abdominal pain, if that makes sense to you. Okay, if it's like a cramp in the calf of their leg, maybe there's a clot there, right? So now, like, let's go back. Fibrinogen versus fibrin degradation products, fibrin split products. Okay, what's the difference? This is just a little review. Fibrinogen, right? It's okay, so a low level suggests that there is an increased consumption of clotting factors. Okay, so that means that a normal fibrinogen level means normal, right? If it's low, that means fibrinogen. If fibrinogen is low, that means that somewhere in the body there was damage to tissue, and your body then sent all these fibrinogen molecules, whatever, to that area to cause a clot formation. Okay, so it took it out of the system to go form a clot. So if that fibrinogen level is low, that means they're making a clot somewhere. On the same note, fibrin degradation products also show that there's a clot somewhere, but they're going to be elevated, right? Because your body's producing these to go break down the clot, okay? So these are just like signs and symptoms that there's clots forming and being broken down in the body, but they're letting us know that there's clot somewhere. I hope that makes sense, and I hope it didn't confuse you. Just remember, fibrin low means that there's clots forming. Fibrin degradation products, D-dimer high, means that there was a clot somewhere and your body's trying to break it down. But they're both showing that there's clots that exist. Okay, blood transfusions. Okay, so we already kind of talked about this, so this is a review. So blood transfusions are indicated for severe anemia, traumatic blood loss, post-surgical recovery. Non-hemolytic reactions, which are common of blood transfusions, okay, they cause mild symptoms like fever and chills versus hemolytic reactions. Those are severe. Those are symptoms like back pain and hematuria or blood in the urine. Okay, so if your patient has a blood transfusion reaction, it's important for you to kind of understand if it's non-hemolytic or hemolytic. Remember, lysis, lytic means slicing, breaking down, cutting down, breaking apart, right? So hemo, blood, lytic means we're going to break down blood things. That's not good, right? Blood components. It's not good. That reaction is much more severe and more of an emergency, but both need to be seriously taken into consideration. Okay, so when we administer products, transfusion reactions are a concern, and you should always be monitoring for these, okay? So the two main categories, like I just said, are the non-hemolytic and hemolytic. Each type has different causes, symptoms, and implications for how you're going to take care of that patient, okay? So like I just said, you need to recognize the signs of the reactions early and prevent serious complications. Now, you have to follow the policy of the facility in which you work, and every facility might have a little different variation on their policy, but there's always going to be the double check to make sure that the type and cross before we give the blood. And there's going to be lots of documentation. You're going to be doing vital signs before you give the meds, right? Before you give the blood. You're going to be doing it very frequently thereafter, 5 minutes after, 10, 15 minutes, depending on your policy for the first hour. And then you start spacing it out. Giving blood, you do not want to just hang blood and leave the room. You never want to do that. A nurse needs to stay at the bedside to monitor that patient in that initial stage when they first start receiving those blood products, because we are humans and things can happen. Who's to say that somebody might have mislabeled the blood bag? It has happened before, or there was just some oversight of something, or maybe what if when we did the type and cross, somehow the tube got mislabeled with the wrong patient. Crazier things have happened. So, and even when you have the right compatibility of blood products, so like you have an AB positive patient, it's AB positive blood product, you can still technically have reactions. Okay, so different antibodies are in different blood products, and you don't always know if there's going to be a reaction. So that's why we stay at the bedside and we watch. This is a 1-to-1 for so many minutes, whatever your policy says. Okay, a good rule of thumb is typically the first hour you are really watching that patient very closely. Okay, that's pretty standard across the board in most facilities and places. Um, this is where it's really nice when it's not nice for the patient, but it's nice for the nurse when you have multiple patients in one room, because you can still eye your other patient, while you're monitoring this one patient kind of thing. But the way the world is, individual private rooms. And so you are going to need to, if your patient receives blood, you need to notify your charge nurse so that they can redistribute any sort of critical tasks for your other patients, because you're going to be on a 1-to-1 with this patient for at least a hot second. Okay. So very important to say that. So now let's talk about non-hemolytic transfusion reactions, okay? So non-hemolytics, okay, they are the most common, okay? They typically occur because the immune response to cytokines, which are the small proteins released by white blood cells and blood products, okay? These cytokines can accumulate during the storage of that blood, and it causes a mild immune response when it goes into the system, okay, into the blood, into the patient. Let's just say that. So the symptoms of non-hemolytic, okay, patients might develop a sudden fever, chills, and just general malaise, just discomfort, kind of feeling, I want to say flu-like. They just feel kind of crummy, okay. Normally when patients need blood, you give them blood, they feel amazing. Like all of a sudden I have energy, my head is clear. If they start to feel more crummy, that might be your first sign that there's a non-hemolytic reaction, okay? Not always the case, but it should be something that should just give an extra little notice to your patient, okay? So this typically occurs within the first 1 to 2 hours of the transfusion, but it usually resolves pretty quickly after that once the transfusion is stopped, okay? So do we stop these? Mm, it depends. If a patient develops a fever, the transfusion should be paused, okay? Your vital signs are monitored closely. We're going to give that patient antipyretics like acetaminophen, because we want to manage that fever, and the transfusion you might be able to resume it cautiously if those symptoms stay mild. Okay, so we're going to pause it. If they develop a fever, we're going to pause it. We're not going to like stop it. We're going to pause it. And we're going to give them antibiotics. We're going to take their vital signs. You're going to follow policy. Very important. You're going to have a policy on this. I promise you. You're going to notify the provider as well, because they need to know if there's reaction, and you're going to use their guidance. And so if they tell you pause it for X amount of minutes, give Tylenol, reassess, as long as everything's stable, nothing's got worse, you can resume it. That is a normal order, just so you know. Okay, I know a lot of people think any reaction, stop it and call all the people. That's not always the case, okay? That's why it's important for you to know the difference between non-hemolytic and hemolytic, okay? So, next thing. Okay, so like I said, if they develop a fever, we may pause it. Okay, so for patients that have a history of this kind of reaction, again, before you give blood products, it's really important for you to ask if they've ever had blood products before. And if they have they had a reaction and what that reaction was? Okay, so if they have a history of these mild symptoms, okay, um, we can possibly give leukocyte reduced blood products, okay? And these are the blood products that have been processed to remove the white blood cells, which is going to reduce the likelihood of that cytokine buildup and future reactions, okay? So that's non-hemolytic. Now let's talk about hemolytic. This is probably what you think of more when you think of a blood transfusion reaction, okay? So acute hemolytic transfusion reactions are more severe and occur due to the ABO incompatibility or other antigen antibody mismatches, okay? In these cases, the person receiving the blood, their immune system is attacking the transfused blood and the RBCs, and they're seeing those RBCs, the blood that's being transfused, as foreign invaders into their body. Okay, so they're going the person getting the blood's immune system is attacking the new blood, causing them to break apart, hemolyze, and release hemoglobin into the bloodstream. So, what are the symptoms going to be in this? This reaction can be life-threatening, obviously, and it has like a variety of symptoms: fever and chills, similar to non-hemolytic, but it's often accompanied by other symptoms like severe pain, low back pain, flank pain. This typically occurs in the hemolytic reactions because the kidneys are working to try to filter out the hemolyzed RBCs, and that can cause the kidneys to be super irritated and they can be very painful. So flank pain, this is probably hemolytic, okay? Hematuria. So if they start having blood in their urine, so if they don't have a Foley in them, you want to tell them when you go to we want to probably be doing eyes and nose, but if they were to pee in a urinal or if they were to go to the bathroom, you might want to say, hey, I want to look at it, and for the few hours after you're getting a blood transfusion, like don't flush it or pee into a hat or something like that, okay? So the blood in the urine is what why that happens is the hemoglobin released from those lysed or destroyed RBCs can be filtered by the kidneys, which is going to irritate the kidneys and cause pain, and then that's going to lead to the dark or red tinged urine. Okay. You also might see hypotension and tachycardia. So those are signs that reflects the body's response to the sudden immune attack on the blood cells and blood loss from the RBC. So you're losing blood because the blood is being broken down in the vasculature. It's not like you're bleeding out and then it's being filtered by the kidneys. So you're going to have a decrease in the volume because your body's going to try to get rid of this toxicity, foreignness that's in the blood, filter it through the kidneys, get it out of here, okay? When it sees it as foreign. Oops, went too far. Okay, so that's kind of the difference between non-hemolytic and hemolytic. So they both might have fever and chills, but we're non-hemolytic, that's kind of just a general malaise and fever and chills. There's no extreme pain. Probably non-hemolytic. That pain, blood in the urine, vital sign changes, other than temperature, probably hemolytic. Okay, so what do we do for hemolytic? So the management of it. Okay, so, oh, I forgot to say, sorry, back it up. Chest pain, dyspnea, they might have that as well. So, as the free hemoglobin affects the organs, they may experience respiratory distress, chest pain. So, what we're going to do, now we can go into it. So, we're going to stop the transfusion immediately. Okay, first step, stop it. Okay, and any suspected hemolytic reaction to prevent hemolysis. So, even in the non-hemolytic reactions, we're going to stop the infusion, but we're going to stop it by pausing it, thinking that we might come back. But in a hemolytic, we're definitely stopping it. Okay. Are we going to throw the blood tubing away? No, because we're going to test it to see what's going on, right? Okay. We are going to. Are we going to flush? No. Why would you give them more? Right. We're going to stop it, and you're going to follow the policy in your facility as far as how do you handle a hemolytic reaction. So you might be asking yourself, what do you need to do and in what order should you suspect the hemolytic reaction? Okay, so I really do want to spend some time on this for a second. So the first thing, what we already said, is you're going to stop the infusion immediately. but you're going to maintain that IV access with normal saline, okay? Um, this is going to prevent further exposure of the incompatible blood and prepares the IV site for potential treatments or medication administration. You're going to notify the provider, promptly notify the healthcare provider, and you're going to notify the blood bank or lab, wherever the blood came from, okay? They will probably guide you on your specific policy at your facility. Now, what I'm saying again, if your facility has different rules and steps, you follow that. But this is kind of generic advice. Discontinue and stop it. We're going to make sure that they still have a patent IV somewhere, and we're going to be giving them some normal saline because remember, they might have hypotension due to the lysis of it may lead to hypotension. So we're going to be kind of doing some fluid volume replacement and normal saline. You typically already have an order of saline with the blood products. You're mixing them, so you should already have saline at the bedside. Okay, so you're going to notify the person, the provider that is on call for your patient that ordered the blood, and or just the whoever it is, the intensivist or the internist, whoever's like managing the patient's care. You're also going to notify the blood bank and your charge nurse. Okay, so this is because you want to ensure that the appropriate medical response is initiated and additional interventions might be needed to stabilize this patient that you don't have orders for. Obviously, if you're in the ER, you just call them. They come at your bedside. If you're in the ICU, hopefully you have an intensivist right there at the bedside, so it's quick. But you want to let them know. You're going to be monitoring vital signs very closely. You are already monitoring them, okay? But you're going to be looking especially for those signs of hypotension, tachycardia, fever, respiratory distress, the pain and the different things, the urine output. You're going to be looking at all those things, okay? You're going to be assessing, and after you monitor the vital signs and assess your patient, you want to be documenting it, okay? Document the patient's symptoms and any interventions that you did take. Symptoms like um, fever, chills, flank pain, chest pain, dark urine, feeling of impending doom. Don't ever like brush that off. If somebody just feels like I just feel like something bad's about to happen, please listen to it. That's a legit thing that a patient says, and you should listen to it and do some further investigation as to why they're feeling that way, because they might be saying it like in a psychological sense, but they're actually feeding off of a physical feeling that's coming from somewhere. Okay. So you're going to send blood and urine samples. You're going to follow the protocols for obtaining and sending blood and urine samples to the lab. These samples are needed for additional testing to confirm the hemolytic reaction and assess the patient's hemoglobin and bilirubin levels. So you're going to be sending the tubing, the the blood and the blood tubing that you were administering, but you're also going to be doing probably another type and cross match. You're going to be sending a CBC so that we can be looking at H&H levels. And again, you're going to follow your protocol, but you're going to be pulling blood from a different line. You're not going to pull blood from the line that you were transfusing that blood in. You're going to poke the patient again. You're going to send lab blood specimens to the lab. You're going to do another type and screen, and you're also sending the blood tubing so they can test to see what happened. Okay. You're also going to just be prepared for further interventions. So that might include administering antihistamines, corticosteroids, or giving fluids, okay, to manage those symptoms that happen, okay? Um, they might require critical care support depending on the severity of the reaction, and you're going to stay with the patient. You're going to remain with the patient and provide reassurance and monitor for any further changes in status. Um, you're not going to just leave the room. You're going to be calling from the room when you do these things. You want a nurse to be at the bedside because this could turn critical, right? So you're going to follow. Now, how long do you stay with them? That's nursing judgment and or policy. Your policy might say you have to monitor them for a certain length of time, then you're definitely doing that there. This is not something that we delegate to an unlicensed assisted personnel. This is for an RN to monitor, right? Is this for an LVN? No, they can't give blood. This is RN. So that's very important to say, okay? Okay, so anaphylactic reactions to blood transfusions. Okay, those are very rare, but they can happen and are super serious, as obviously concern anaphylactic reaction always is. Okay, so what causes that is that immune response to plasma proteins. The symptoms include hives, itching, respiratory distress, and even cardiovascular collapse. Just like if a bee sting caused anaphylactic reaction, same symptoms can occur, okay? If this reaction is suspected, again, stopping the transfusion, and we're going to give epi, just like with other anaphylactic reactions, okay? So Quick action can prevent severe complications and highlighting the importance of the close monitoring while you're giving the blood products, right? That's why we just don't start the blood and leave because this can happen. Hopefully it never does, but still saying. Okay, so nurses play an important role, as obvious, in safe blood transfusion practices. Before you initiate a transfusion, it's super important to verify the patient's ID and blood compatibility thoroughly. Most policies and most facilities require two nurses, right? So we're double checking. Um, you want to monitor the vital signs before, during, and after the transfusion. Okay, because we also want to be monitoring and assessing for those early detections of those adverse outcomes. So fever, chills, malaise, flank pain, urine, bloody urine, respiratory distress, any of those things, itching, hives, okay? We also want to talk about any concerns the patient might have and cultural beliefs around blood products to ensure that we are respectful of their culture, religion, and wishes, but also that they're fully informed to know whether to choose to receive the blood products or not. So, a little bit more on that. Okay, blood transfusions and blood product administrations, as we know, are life-saving interventions, but they can present those unique challenges when patients and their families have cultural, religious, or personal beliefs that conflict with giving and receiving blood products, okay? So as a nurse, it's important for you to understand, respect, and work within these beliefs to provide safe, ethical, and culturally sensitive care. Okay, so patients might have religious or cultural objections to blood transfusions. Okay, the one that we always talk about in nursing that's more common is Jehovah's Witnesses. Those people that follow and identify as a Jehovah's Witness, they often refuse blood transfusions based on their religion, obviously. So they view it as a biblical mandate to avoid taking blood into the body. Similarly, certain Native American and or Eastern cultural beliefs may see blood as sacred or intrinsic to somebody's identity, and that will affect their perspective on blood donation and or transfusion and receiving it, okay? Other patients might have just personal beliefs based on fear of receiving blood that has bad things in it, mistrust of the healthcare system, or they may have past experiences or concerns like bloodborne infections, transfusion reactions, or just feeling uncomfortable about receiving somebody else's blood. Patients from cultures with strong emphasis on bodily integrity, like more commonly in like Buddhist and Hindu groups, they also might be hesitant to accept blood products because they view the body as pure and a unified whole. So receiving some other piece of somebody else's body into your own is not always accepted. So as healthcare providers, it's our responsibility to honor the patient's autonomy. They do have a right to make a decision about what treatment they receive. Okay, open, respectful communication is super important when discussing blood transfusions. Don't be judgy. Okay, start by asking those open-ended questions like, "What are your thoughts and feelings about receiving a blood transfusion or blood? Do you have any personal or cultural religious beliefs regarding blood products? If so, can you talk about them?" This kind of open-ended approach will help um, allow patients to tell you and share their perspectives without feeling judged or pressured, but they still might, especially if they've had encounters in the past, okay? But once a patient's beliefs and values are understood, you need to provide a clear, unbiased information about the risks. So even though they say, I don't want the blood products, you still are responsible for providing them with risks and benefits of transfusion therapy, okay? So you want to make sure that they have received it. Okay, so consent, you're not consenting, you're just making sure and ensuring that they had all their questions asked, right? So you want to say, you know, these are the risks, these are the benefits that the provider explained to you. Do you have any questions about that? Do we need to pull the provider back in here to kind of go over that with you? You want to ensure that they truly understand both, okay? A lot of times you say, look, we just have to make sure that you understand the risks and benefits of this. You just listen to it, and I will still respect your decision. A lot of times they'll be willing to listen, okay? So reassure the patient that they have a voice, okay? Reassure them that you are going to honor their decision, okay, no matter what their beliefs and whatever their decision might be, okay? So, also just collaborating with family and spiritual advisors when it needed. Sometimes you can get, sometimes people just need the blessing of a family member or a religious leader to receive these products. And if that's the case, you can coordinate getting them on the phone, getting them there in person. So, whatever the case may be, that is what you should be doing to support your patient. So let's talk about HIV. Okay, HIV, or human immunodeficiency virus, primarily targets CD4 T cells. Okay, T cells are those fighter cells, remember? And so it gradually weakens the immune system, leaving the body vulnerable to infections. HIV is transmitted through blood, sexual contact, and mother to child. Okay? Without treatment, the virus leads to immunodeficiency, making individuals susceptible to opportunistic infections and cancers. Remember, people don't die from HIV, they die or AIDS. They die from an infection because their immune system has gone bad, basically. Okay, so the HIV virus infects and depletes those CD4 T cells, which are the central to immune function. As those cells are lost, the body's ability to fight infections diminishes, leading to a high risk for opportunistic infections, more commonly things like pneumonia, but also things like tuberculosis. Over time, the depletion progresses, eventually compromising the immune system and life-threatening degree, where if you don't treat it, then patients can easily die from just minor illnesses. So what we give is antiretroviral therapy, ART is sometimes how it's referred to. Okay, so that's the cornerstone of HIV treatment, and it involves a combination of drugs that target different stages of the HIV life cycle to control the virus. So it's keeping it from replicating, it's keeping it from um, infecting and doing its damage, basically. So the goal of ART is to suppress the viral load to undetectable levels. You will never be cured. You will always still have it in your system. Okay, but we may not be able to detect it if ART therapy is effective. Okay, so that's not only going to help preserve the patient's immune function, but also significantly reduces the risk of transmitting HIV to another partner, like sexually transmitted or through blood or whatever the case may be. So first, we're going to talk about some considerations for ART and its purpose, potential side effects, and all those kind of things. So the purpose and goals, like I just said, is to suppress the patient's viral load, ideally to undetectable levels, okay? Achieving undetectable viral levels helps the immune system remain intact, particularly preserving CD4 T cells, which HIV targets and destroys. Maintaining immune function is crucial for preventing opportunistic infections and HIV-related illnesses. ART also plays a role in reducing the spread of HIV, like I already told you. Okay, so what are some of those side effects and some of the toxicities that we have to worry about when you have a patient that is receiving antiretroviral therapy? Okay, so even though it's highly effective, it does come with those side effects, which can be it can vary debating on the drug class it comes from. So common side effects include GI symptoms, nausea, vomiting, diarrhea. Super common, especially in drugs like protease inhibitors. These can impact adherence to actually taking the meds if they're severe. So we often recommend taking the medication with food or adjusting the timing of the dose to help alleviate the symptoms. So if they are going to have diarrhea after the fact, we want to make sure that they're not taking it right before they leave the house, kind of thing. Okay. So they can also cause liver toxicity. Some ART drugs can cause hepatotoxicity. So we're going to be doing liver function tests regularly. We're going to be monitoring those LFTs. Patients with pre-existing liver conditions like hepatitis or B or C, they're at higher risk and might need to be modified in their treatment plan and some of the drugs and or dosages that they're given. Okay. Metabolic issues. So ART, particularly older regimens, so the ones that we started like a long time ago, the advancements have come a long way, just even in the past 10 years. But um, some patients have metabolic side effects, okay? So like abnormal fat distribution, hyperlipidemia, and insulin resistance. So the newer ART options have fewer of those metabolic side effects, but we still typically do regular monitoring for lipid levels, blood glucose, and weight, okay? Okay, so the big thing on here is adherence. We want patients to be compliant with taking their meds, right? Because if they skip out a day or two here, a week there, whatever there, it's not going to fully suppress. They're going to be more at risk for transmitting and all those other things, okay? So constant adherence maintains that viral suppression and prevents the development of drug resistance. If a patient misses a dose or takes their medications inconsistently, HIV can mutate. Okay, the virus itself can mutate, developing resistance to the current drugs. We don't want that. Okay, Non-adherence is one of the primary reasons for art failure. As nurses, we need to emphasize to our patients that it's so important for our patients to adhere to the treatment plan, taking the meds as prescribed, as ordered, as often, the same amount, and all that kind of stuff. Okay. This might include setting reminders up. You might have to teach them how to set up reminders on their phone for an alarm to go off every single day, or involving family and friends in their support system to help remind them to do it. Or if they don't have transportation to go to a pharmacy to pick them up, just helping them think through the possible challenges that might occur and helping them think through and set up a plan so that they can be successful. Okay, super important for you to be judgment free and just super supportive. Okay, so before a patient starts taking these meds, again, we're going to be educating them on everything. We want to make sure that they're ready to take them, that they've fully accepted the risks of not taking these meds and going through art therapy, that what it will lead to. Okay, and then we also want to do those baseline labs of the things like for like liver. Lipids and all those kind of things and glucose levels, so that if we see a change, we know that it wasn't something that was pre-existing. So now cancer in the ICU. Whew, almost done. Okay, so common cancer-related complications in the ICU. In the ICU, certain cancer-related complications can escalate quickly. Okay, so one of the ones that we're going to talk about today is tumor lysis syndrome. That is a metabolic emergency that occurs when a large number of tumor cells release intracellular contents into the bloodstream. This leads to hyperkalemia, hyperphosphatemia, and hypocalcemia, which can cause serious cardiac and renal issues. Obviously, when our electrolytes are out of whack, it can affect your heart, right? And your kidneys. So, management for this includes aggressive IV hydration to protect the kidneys, medications like allopurinol to manage uric acid levels, and close electrolyte monitoring. Another complication is spinal cord compression. That can be caused from tumors that metastasize to the spine. Patients typically present with back pain, weakness, or loss of bowel or bladder control. Weakness, like in like lower extremities, kind of thing. We start treatment with corticosteroids to reduce that inflammation initially, and it may proceed with radiation or surgery based on the imaging results. So it's super important that that prompt diagnosis and intervention are given before further damage occurs. Okay, a little bit more about hypercalcemia of malignancy. Okay, so it is a frequent complication, especially in cancers like breast cancer, lung cancer, and multiple myeloma. Elevated calcium levels can cause confusion, lethargy, and even cardiac arrhythmias. How we're going to manage this, we're going to focus on the IV hydration and we're going to promote renal excretion of calcium, biophosphonates to inhibit the bone reabsorption of it, and in urgent cases, calcitonin for a quick calcium reduction. It binds the calcium and the free calcium in your system. So now, septic shock and immunocompromised patients. So infection is always a constant threat in our cancer patients, right? We're all, immunosuppression might be because of the cancer, or we might be suppressing the immune system to treat the cancer. Okay, so this can lead to an increased risk for being septic and leading to septic shock, especially in those neutropenic patients. So key signs include fever, hypotension, tachycardia. Immediate broad spectrum antibiotics are critical. Time is of the essence. And supportive measures like fluid resuscitation, vasopressors to help maintain the perfusion across the body. The ICU nurse, you just like anybody else with septic shock, you're going to be closely monitoring the patients. You're going to be titrating drips and adjusting it based off of reactions and vital signs and assessments. And you're going to be looking for signs of deterioration, giving that these patients are highly vulnerable, okay, to deterioration. They don't have as many compensatory mechanisms in their system. Their body has been stressed to the max, okay? So things to think about. So DIC in the nursing role on oncologic emergency. So we already talked about DIC in general, but this is specific to with oncology, okay, and cancer patients. So remember, DIC is that severe clotting disorder that can affect patients. It's clotting and bleeding, right? So patients with advanced cancer can get DIC as well. So that leads to the clotting and the bleeding. Management's going to include addressing the underlying cause, obviously, but it's not like cancer is a quick snap your fingers fix, okay? Platelet and FFP transfusions to replace those depleted clotting factors, and sometimes that low dose heparin that we already talked about, okay? So there's not anything necessarily different. It's just I want to make sure that you are aware that this is something in oncologic emergencies. So the nurses in the ICU play a critical role in managing them. So you're going to be monitoring the signs, lab values, coordinating with the healthcare team, providing that emotional support to the patients and their families. But it's so, so, so important to early recognize that patient might be going into DIC, okay? So that intervention can be initiated and hopefully significantly impact the outcomes of your patients, okay? So just remember that that is a thing. And then supportive therapies, this is something that we kind of talk about in a lot of things, but remember, we're not just here to treat a body, we're here to treat a whole person, okay? So we want to be thinking about things to reduce their stress, which will help their immune system. We want to improve their mood. It could be music, it could be guided imagery, it could be self relaxation, it could be figuring out a way to take them outside for some sunshine if it's not contraindicated. It could be getting loved ones to be come up there so they can talk and see people that they're familiar with. Just anything you can do to support these patients and their holistic view is super important to their overall well-being and their outcomes. Little summary of what we talked about today. You can pause to read, and that is the end of Module 11.